Welcome, everyone. It's a pleasure to have a very good speaker tonight. And just before I'll let Dr. Allaire, the moderator, talk to you. My name is Diane Franqueur. I'm the CEO of SOGC, and I just want to make a quick announcement. So we're going to postpone the call for nomination. There's very good working group committees of the board position. There's a lot of stuff that is available, so please take a look at it. So we're gonna send an email probably Friday morning because we have a big day tomorrow. So I would recommend that you watch the news. You're gonna hear about us, about the great news. And so we just pushed it until Sunday. And so you still have time to fill your application. It's just a little survey monkey. And I just want to tell you that SOGC is doing well. We have a lot of activities. We have a lot of fun, and everyone is happy and committed to try new stuff. So please get engaged, give us idea. We are ready to move from what we used to do and repeat year after year. We want to try all kinds of new stuff to make sure that we're going to be able to meet all your learning objectives. So with that, I will ask Dr. Allaire to present our great speaker for tonight. Have a good night, everyone.
Thank you, Dr. Franca. It's my pleasure to be here tonight to moderate this very exciting session. Before I introduce our speaker, I just wanted to talk a little bit about the structure of the evening. So Dr. Bougie will have a presentation that lasts about 40 minutes and leave 20 minutes for a question and answer period. Due to the size of this group, we will be unable to take verbal questions, but please put your questions in the chat, and I'll be moderating the chat and moderating the question and answer period at the end. Also, for those of you that may arrive late or leave early from the webinar or want to share this information with colleagues, the webinar is being recorded and will be available on the SOGC website under the forum tab or forum section. So without further ado, I'd like to introduce our speaker tonight. So Olga Bougie. Dr. Bougie is a rising star of the gynecologic research world in Canada. She's currently an assistant professor at Queen's University in the Department of OBGYN. She attained her medical degree at Queen's University and completed her residency at U of Ottawa. She subsequently completed the AHL Fellowship in Minimally Invasive Gynecology at U of Ottawa, as well as a Master's of Public Health, Clinical Epidemiology at Harvard University. Her clinical interests include endoscopic surgery, complex benign gynecologic cases. Her research interests include endometriosis and patient-centered outcomes in gynecology. So welcome, Dr. Bougie.
Wonderful. Thank you so much, Dr. Allaire, for that kind introduction, and a great thank you to SOGC for inviting me to present on this topic. We have some very exciting new therapies available for management of patients that we see living with endometriosis and uterine fibroids, and I'm thrilled to be here with such an engaged crowd speaking about this today. The following are my disclosures. And I do want to bring attention to the fact that a number of these are obviously companies that are involved with medical therapies of these, but all the slides that are presented have been scientifically reviewed and present the scientific literature in this area. So the following are objectives. I would like to review and make sure that we're all understanding the pathophysiology of endometriosis and uterine fibroids, as well as the impact of these conditions on patients' quality of life. As we're discussing new therapies, it is important to kind of consider how they impact the pathophysiology of these conditions. We'll discuss the changing paradigm with respect to the long-term management options of endometriosis and uterine fibroids, in particular uterine fibroids. Looking at medical management, we haven't had really great targeted options. So this is a time when that landscape may be changing. And finally, as we mentioned, we have set aside quite a bit of time for discussion. So this is sort of meant to be a broad overview of the topic with, we really want to hear the questions that the audience has for us to evaluate the side effects and safety concerns with long-term management of various modalities. So I'll start with endometriosis. As many of us know, and again, I'll go through these introductory slides a little bit faster, but please, include questions if you have any that arise. We know that endometriosis is a complex chronic condition that occurs with endometrial-like tissue implants outside the uterus to form lesions, cysts, and deep nodules. I used to really define it as a gynecologic condition, and I think now many of us that see these patients appreciate that it's a chronic, multisystemic, inflammatory, recurrent condition that is hormonally and specifically estrogen dependent. When we look at the epidemiology of endometriosis, the sort of best evidence so far suggests that it impacts about 5 to 10% of the female population. We have really poor literature looking at how this condition affects transgender, gender diverse, and two-spirit people. In terms of presentation, a substantial percentage of patients, so up to 1 in 5, will actually be asymptomatic, but most commonly patients tend to present with dysmenorrhea or pelvic pain, as well as subfertility. It's important to note that there's a significant delay often to diagnosis and effective treatment, with global survey indicating that over 60% of patients living with endometriosis were diagnosed or had an onset of symptoms prior to age 30, really necessitating the need for effective medical management options. Looking a little bit closer at the pathophysiology of endometriosis. So we used to say that endometriosis is endometrium outside the uterus, and many patients have actually corrected us on this. And so we have to be really careful to say that it's not the endometrium. And those key differences are important as we consider medical therapies. So endometriosis differs from endometrial lesions because the endometriotic lesions kind of become smart so that they grow and proliferate. Some of the key changes are that although it's responsive to estrogen, it becomes resistant to progesterone, and that becomes one of the difficulties in finding effective and sustained treatment for endometriosis. As we know, one of the other challenges is sort of the variable nature of the disease, and from a surgical perspective, that we see many different phases of endometriosis. Some of the lesions there that we're seeing are in the vagina, in the lung, in surgical scars, and then you can see the GI system, the appendiceal involvement there as well. So it's really challenging that this condition includes superficial lesions to deep lesions, and obviously the surgical and the medical management of those need to be tailored. What is the impact of endometriosis to our patients? I mean, we obviously see these patients day in and day out and hear their stories of how this condition and potentially the delay to diagnosis and the treatment lag or difficulties with treatment have impacted their lives and their life journey, starting early on with adolescents, often missing school or having challenges in their education and their relationships, moving forward to career development, fertility considerations, family building, etc. And so many of us are obviously, I suspect kind of all of us and certainly SOGC are working to change this picture so that we diagnose endometriosis early and we treat those patients effectively, both with surgical and medical management options. Again, the paradigm is changing. Certainly, there's a very good role for surgery, and as surgeon myself, this is really important. But we're now appreciating that in this chronic long-term condition, medical management really has to be a cornerstone as well. Certainly, there's a number of guidelines for endometriosis, and so I've tried to include and review these in the next slides. I do want to acknowledge, obviously, that our own SOGC guidelines are currently in the process of revision, so some of the information that I'll present is more contemporary than what's presented in the guideline. When we consider the goals of our care, certainly we want to treat the patient and treat their concern. So that may include alleviating their pain, preserving their fertility, if that's an important consideration for patients. For those that do have surgical management, we want to prevent recurrence. We want to help patients adhere and find an effective medical management option that improves their quality of life. And in particular, a consideration, and as we'll see in the therapies discussed today, is to mitigate bone loss, because many of the therapies for endometriosis lower estrogen levels. As I mentioned, obviously, we're aware of the fact that it's a condition that thrives with estrogen. And so as we lower those levels, we want to make sure that they're at a level that estrogen's at a level where bone is still being protected. Certainly a number of considerations as we consider medical management include efficacy, the symptoms that patients are experiencing and that we're trying to treat, their fertility desires or plan, again, the tolerability of the medication, cost, and we can certainly have a discussion about that today, and then patient choice and desire as well. So the following, oh, sorry. I guess that was already over recorded, sorry. So the following, I'll just start reviewing the available options. So we'll start with the combined oral contraceptive. This is typically the first line medical therapy available for patients with endometriosis, and certainly does have RCT evidence supporting its use. It's most effective for relief of dysmenorrhea, and that may include for patients that also have primary dysmenorrhea as well. We see less efficacy for patients that have other pain symptomatology related to endometriosis, such as dyspareunia or chronic pelvic pain. In Canada, we see that many patients are started on the combined oral contraceptive for the management of endometriosis-related pain, but continue to have symptomatology. So about 2/3 of patients presenting with endometriosis have tried more than one combined oral contraceptive and still continue to experience symptoms. So we need to have other options available as well. Progestin therapy is typically another first-line therapy that can be initiated, or a second line. Progestins often work beyond central effects. So in addition to lowering estrogen, they're anti-proliferative, anti-inflammatory, and anti-angiogenic. A common progestin that we see that's specific for endometriosis is Dynagest, and here we see the randomized controlled trial demonstrating its efficacy above placebo. So certainly at 12 weeks and then further on in time with long-term use, we see sustained relief in symptoms and pain. GnRH agonists, so there's a number of these available. One of the more common ones that we are familiar with as gynecologists and for the use of endometriosis tends to be leuprolide, but there are other depot, subcutaneous, and nasal options available. These do have good efficacy for the management of pain with endometriosis, but we know that often treatment, and specifically long-term treatment, is affected by bone loss and other symptoms associated with the GnRH agonists. And so over the last couple of years, the new therapies that's come out is GnRH antagonist. And this is sort of one of my favorite medical school questions, because it is confusing that two seemingly opposing medications are doing the same thing. So we'll just spend a little bit of time reviewing the mechanism of action of GnRH. So as we know, GnRH stimulates the anterior pituitary in a pulsatile fashion. So it comes to the receptor and then binds off. And the pulsativity of that action influences whether LH or FSH is released, so is different in different types of the cycle. So the GnRH binding to its receptor and releasing from that receptor is actually a really, really key kind of step in its mechanism of action. So GnRH agonists bind the receptor and block it from coming off. So we get a flare effect initially of the gonadotropins being released, and there's a number of different ways to mitigate this flare. And then it continues, so exposure to it desensitizes the receptor, and we see profound inhibition of the hypothalamic pituitary ovarian axis. A GnRH antagonist works like any other antagonist, so it competitively binds the receptor and blocks some of them, allowing for dose-dependent suppression of an HPO axis. And so now we have a couple of GnRH antagonists available. One that's been available in Canada for a few years is elagolix. It's a it's an oral formulation available in 2 doses for the management of endometriosis and endometriosis-related pain. So we have a 150 milligram dose that's once a day, and then a nearly full estradiol suppression dose of 200 milligrams BID. The following are the trials from the elagolix studies, demonstrating, again, a nice dose response from placebo. The partial suppression dose of 150, we see improvement in dysmenorrhea at about 46%, and then with the nearly full suppression dose, 75% improvement in patients' dysmenorrhea scores. The second graph you see there is non-menstrual pelvic pain. So as we're aware, there are many other contributors to patients experiencing chronic pelvic pain, in addition to endometriosis, and menstrual suppression is often not as effective for mitigating all of that pain. We do see an improved, actually, placebo response. So 36% of placebo patients experienced improvement in the non-menstrual pelvic pain, but there wasn't as much of a difference in the medical treatment, although it was still significant improvement at about 50 and 55%. Over time, we see, we do see continued improvement, and with long-term use, some additional benefit as well. So the new medication that we have available that's been out in Canada and approved for just a couple of weeks now in the month of February is Myfembree, and this is a combination therapy for relagolix. The active ingredient in it is relagolix, which is a GnRH antagonist of 40 milligrams. The tablet also contains add-back therapy already included, including estradiol of 1 milligram and norethindrone acetate at 0.5 milligrams. So this is a full suppression dose with add-back added back in, and it's a daily therapy, which is currently indicated for premenopausal women for the management of moderate to severe pelvic pain associated with endometriosis, as well as the management of heavy menstrual bleeding associated with uterine fibroids. So in this slide deck, I'll review the studies for endometriosis, and then we'll come back to look at it a little bit more closely for fibroids. The sort of pivotal trials that were reviewed by the FDA and Health Canada for relagolix combination therapy were the SPIRIT trials, which were replicate double-blind, randomized, placebo-controlled, multinational studies that happened mostly in North America and Europe, with over 1,200 patients included overall. Patients were randomized either to placebo, relagolix combination therapy, so that's what we have available right now, or relagolix on its own, which is not available as a treatment option. In that arm, patients initially had sort of the GnRH antagonist alone, and then it was switched to a combination therapy. And those patients were followed for 24 weeks, and I'll present those findings today, now. The primary endpoints were improvement in dysmenorrhea scores. So the mean dysmenorrhea on a numeric rating scale for patients included was 5. And then the clinically significant difference that was decided on as a primary endpoint was a reduction of at least 2.8 points, or responders were defined as improvement in non-menstrual pelvic pain over 2.1 points. So here are the co-primary endpoints for both trials. We can see that there was a significant improvement in dysmenorrhea and non-menstrual pelvic pain in both groups. So either the relagolix combination therapy treatment arm, or those that had relagolix on its own and then were switched to the combination arm halfway through. They both had pretty similar results. So compared to placebo, where the improvement in dysmenorrhea was about 27-30%, we saw, again, about 75% of patients were responders. And again, less of a response with in terms of non-menstrual pelvic pain, but still a significant improvement over placebo. This trial subsequently had an extension arm, so I'm happy to talk about that in a little bit more detail. But suffice it to say that after completion of the 24-week trial, patients were then given an option to continue, in which everyone, so the placebo group or the delayed treatment arm, or delayed combination therapy arm, or the relugolix combination therapy arm, would then everybody was switched to relugolix combination therapy and followed for up to 104 weeks. And we see sustained improvement in both dysmenorrhea as well as non-menstrual pelvic pain. So this is demonstrating, again, response to dysmenorrhea. So we can see that the upper black dots there are the placebo patients that subsequently, when switched to the treatment arm, saw improved response in their pelvic pain that was sustained. And this is for non-menstrual pelvic pain. I'm happy to discuss bone density in more detail. Obviously, this is, as I mentioned, a big consideration for patients, and specifically when we're looking for effective long-term medical management option. So the reason why we have the combination therapy arm, or the combination therapy as the medication that's available, is precisely because of this and mitigating other side effects as well as vasomotor symptoms. But we see here that with relugolix combination or delayed, relugolix combination therapy, there was some decrease in bone mineral density that then improved once patients were switched to the combination therapy arm. With long-term treatment, so again, now we have data going out to 104 weeks, so 2 years of extension. Patients maintain their bone density when undergoing treatment with the combination therapy, which obviously is a really important consideration for us. Sorry. Okay. Sorry, apologies about that. My PowerPoint was a little bit frozen and now it's going too quickly. All right, so I think we're right on time. We're about 20 minutes in discussing endometriosis. So next I'll talk about uterine fibroids. As we know, uterine fibroids are very, very, very common. I'm sure most of us see patients every day, and multiple patients that we encounter with uterine fibroids. I always say that if we do an ultrasound for everyone, we'll find fibroids. So we know that by age 50, the cumulative incidence among white patients is around 70% and maybe a bit higher in Black women. About a quarter of those was experienced symptoms, often influenced by the size and location of the fibroid. So certainly a substantial number of those patients will have a heavy menstrual bleeding, which can lead to anemia. Patients may have infertility or fertility considerations and may experience pelvic pain or pressure-related symptoms. There are a number of factors controlling fibroid growth. Fibroids are monoclonal growths in the myometrium that are influenced by genetic alterations, environmental factors, autocrine stimulation, and then as well hormonal influence, including estrogen and progesterone stimulation. So again, here we have the SOGC guidelines from 2015, looking at the treatment recommendations for uterine fibroids, which again are influenced by whether the patient is symptomatic or not. If patients are asymptomatic, generally just clinical surveillance is recommended. If patients are symptomatic, often their treatment will depend on whether they're hoping to enhance or retain or improve fertility. And we can look at sort of available medical and surgical as well as interventional radiology options. So again, today we'll focus on the medical treatment options. This is a little bit of a more succinct summary of what we have available. So looking at the medical side, we have a number of targeted options and then those that are not. Again, when we think about the goals of care, which we keep coming back to, our goal is to treat the symptoms that patients are experiencing. So often if they are presenting with bleeding, to control or stop the bleeding and treat their anemia, and plan then for either surgery or long-term medical management. It is really important to consider that the number of patients that are undergoing surgery, in about a quarter of women undergoing elective hysterectomy or fibroid removal are anemic, and this substantially increases their risk of complications. So this is data from Ontario, but certainly would apply, I'm sure, to most of Canada as well, really drawing our attention to the fact that we need to rely on medical management options and high quality medical management options available for these patients, even when we're planning to do surgery as well. So generally, the options available for treatment of heavy menstrual bleeding related to fibroids were really those that were available for abnormal uterine bleeding in general, and included combined hormonal contraceptives, again, progestins, potentially the levonorgestrone releasing intrauterine system, tranexamic acid, and then GnRH agonist or plus or minus add-back. And then again, making sure that we treat patients' iron deficient anemia with iron as well. The new option that we now have, again, is relugolix combination therapy, which is available, as I said, for endometriosis as well as fibroids. And it's the same dose, the same medication that's available for both options. The Liberty trials were those looking at patients with fibroids, so we'll review the data from those right now. Again, women were included ages 18 to 50. They had to have uterine fibroids confirmed by ultrasound, as well as heavy menstrual blood loss that was defined as either 80 cc's per cycle over 2 cycles or over 160 cc's, which is really a substantial loss in 1 cycle. Patients were enrolled in North America as well as the rest of the world. In these trials, they were a little bit more heavy from North America. I'm happy to talk about the patient distribution. I didn't talk about that in the endometriosis trials, but it is important to kind of confirm that in the Liberty trials, about 50% of patients or more that were included were Black women, which is typically what we see, I think, in our clinical population, with those patients having a higher rate of fibroids and typically having a worse disease burden. In total, just under 800 patients were included in both trials. And again, the randomization was similar. So looking either at placebo, relugolix combination therapy, which is the medication that we have available in Canada now, or relugolix and then being switched to the combination therapy. And again, patients were followed for 24 weeks and then had a chance to go into the extension trial. Here, again, the objective was to determine the benefit of relugolix combination therapy compared to placebo for management of heavy menstrual bleeding associated with uterine fibroids, where the primary endpoints really were looked at control of menstrual bleeding. So patients either had to have a volume of under 80 cc's in their menstrual or over 50%, have to have menstrual periods under 80 cc's of menstrual blood loss, as well as a 50% reduction from baseline. So here we can see the study results in terms of reaching primary endpoint. Over 70% of patients on a combination therapy reached the primary endpoint versus about 19 to 15% in patients that were on placebo in the placebo arm, demonstrating a significant improvement with the medical treatment. The trial saw a rapid and significant decrease in menstrual blood loss with relugolix combination therapy. So typically bleeding control was achieved within 1 cycle. And you can see there the change in menstrual blood loss from baseline was substantial in the treatment arms. One of the secondary endpoints was improvement in hemoglobin levels in patients with anemia at baseline. So again, over 50% improvement in their anemia with treatment. In these trials, iron therapy was at the discretion of the provider, so it wasn't mandated that all patients with anemia needed to be treated with iron. However, they were quite closely followed in the trial, so the majority of them received both treatments. Looking at the adverse events that were reported, and I will say that these differed a little bit between the endometriosis and fibroid population, which is not altogether unusual, and I'm happy to discuss that a little bit further. But as expected, one of the most common side effects that patients presented with were hot flushes, and we can see that compared to the placebo arm, there was a slight increase in the combination therapy group, but not particularly clinically significant. Obviously, in the patients that were first treated with relugolix alone, where they had menstrual suppression without add-back therapy, we saw a higher rate of vasomotor symptoms and hot flushes. Other common side effects were headaches, and then you can see some of the other adverse events reported. The headache side effect was higher in the endometriosis population, so in the SPIRIT trials with this therapy, and that may be because this comorbidity is often seen more commonly in the endometriosis population at baseline. And so we're really, I think, at an exciting time when we're having new therapies developed for both endometriosis and uterine fibroids. I think specifically for uterine fibroids, we've been at a point where we're lacking an effective medical long-term option, and many patients are needing that. Many patients experience uterine fibroids close to age of menopause and are wishing to avoid surgery, and certainly we have a significant surgical backlog. So the development, I think, of effective and well-tolerated medications is really going to see a place here. Certainly, when we're looking at future directions, there are still many points to be addressed. Certainly, fertility preservation, more targeted therapies is something that's really a research priority in both of these areas. But it's exciting that we're having new options developed for patients. One thing that's maybe a therapy that is in the future, but maybe is time for us to start looking at and introducing into our practice. I've certainly been, having a discussion with this with some of my patients. Is many patients that undergo treatment or surgery for uterine fibroids talk about recurrence, and we don't really have great ways to counsel them on how to prevent recurrence of uterine fibroids, and we're not sure if menstrual suppression achieves that. There's quite good systematic reviews and evidence demonstrating that vitamin D actually has a significant role in both the development of uterine fibroids and disease burden. And so this is, many patients in North America and in Canada are vitamin D deficient. So this is something that I discuss with them in terms of potentially recurrence of uterine fibroids, particularly after they go surgical treatment, or when they have small fibroids and are concerned about them growing and becoming problematic. Certainly, as I said, many of us are vitamin D deficient, and I think the negative side effects of vitamin D are quite limited. Other treatment options have been specific green tea extract substances as well. So Dr. Al-Hundi, who's quite well known in this area of uterine fibroids, recommends this cocktail. And as I said, there's quite good systematic review evidence for both of these. And so I've started discussing this with my patients, and really would encourage you to kind of review the research for yourself and see what you think. So in conclusion, we have several new options available for the management of uterine fibroids as well as endometriosis now available in Canada. Oh, sorry, double copied that in the conclusion, but very exciting for us to be at this time. Treatment options must be individualized based on patient factors, side effects, and goals of care. And there's still a need for development of more targeted long-term treatment options, specifically considering maintaining patients' fertility desires as well. So thank you so much for listening in and navigating a little bit of my glitches, but we have lots of time for discussion now. So I see there's some things in the chat, and I'll let Dr. O'Leary come back in and moderate the questions.
Thank you so much, Olga. That was a very, very nice review of where we're at with these new options. There's a number of very good questions in the chat, so I'll just kind of go in order right now. But the first one is about the use of long-term Lupron for endometriosis patients.
Mhm.
And would you recommend higher dose of HRT, as essentially these patients are in early menopause, effectively, and maybe the standard Activell dose 1 milligram may not be enough for bone protection or heart protection?
So thank you for that. One point I would say is that often I'll start, especially for patients with endometriosis, we know that they need add-back therapy within 6 months. Often I'll start it with starting GnRH agonists. Again, coming back to sort of patient-centered care, sometimes I'll do higher doses for if they're really experiencing vasomotor symptoms. The 1 milligram of estradiol has been demonstrated to be sufficient for bone protection for those patients. And again, that's sort of what the add-back regimen is in relugolix. So certainly a long-term follow-up of patient demonstrates that is typically enough for bone density protection. I think we have less information on heart, but that would be sort of extrapolated as well.
Thank you. There is a question about the evidence for the use of Lupron for fibroid, Lupron and Dynagest for fibroid. So let's start with Lupron for fibroid management, and then the next question was Dynagest for fibroid management.
Great. So certainly, obviously, Lupron has significant good quality evidence for management of fibroids. The challenge with Lupron comes in that it's very, very good, obviously, for fibroid size reduction. But again, that comes with side effects and considerations of bone loss and heart health that really hinder our ability to use it long term. When we add in the add back, we don't see that reduction in size of fibroids, but typically we'll still see a good improvement in management of their bleeding. So it sort of depends on what patient's primary concern is. And not to keep coming back to relugolix, but that was sort of the thought of developing this medication for making it available for long-term use. So it was trialed for management of heavy menstrual bleeding and has demonstrated efficacy for that. There isn't a significant or as profound reduction in fibroid size as the patients that are treated with a Lupron alone. So if that's the patient that you're seeing who has a very, very large fibroid and mainly has bulk symptoms or other symptoms related to the fibroid size, then likely Lupron would be the choice, or pre-surgery or as you're considering surgery. Dynagest can be used for uterine fibroids, but it's not a specific therapy for the condition.
Thank you. If I may add, I think there's some data that looking at Dynagest in the context of adenomyosis may increase the risk of having bleeding or abnormal bleeding, heavy menstrual bleeding. So to use a bit more cautiously in those patients.
Yeah. I'll kind of share that experience with that. I find again, maybe individuals have different considerations, but often the breakthrough bleeding and the sort of abnormal uterine bleeding when starting progestins, I find is particularly heavier with Dynagest. So while it's very, good for managing pain, in those patients where heavy bleeding is the main consideration, and in the endometriosis patients, like you said, that also have adenomyosis, I'm a little bit more cautious about, starting it. And certainly it's not my go-to option for management of heavy bleeding.
Thank you. Can you explain the concept of add-back HRT and why it doesn't worsen endo or fibroids as it seems counterintuitive?
Yes, thanks. So I wish I had, there's a little graph showing the estrogen threshold hypothesis for fibroids and endometriosis. And so the HRT is sort of at a dose of the early follicular kind of estrogen levels. So it's enough to protect bone and heart, but not enough, and help vasomotor symptoms, but not enough to stimulate endometriosis growth or fibroids. This is the Barberi graph that kind of shows this ideal therapeutic window that we have at about 30 to 50 picograms per milliliters. So again, we have this little window where we're trying to really find the ideal estrogen level, and that's what the sort of menopausal hormonal therapy lies in. So the estrogen that you need to manage vasomotor symptoms and protect bone is much, much lower than what premenopausal women are typically have in terms of circulating estrogen, and is not enough to stimulate endometriosis or fibroid growth as much.
Thank you. Can you speak to the efficacy of the IUS in management of fibroids and any benefit for endometriosis?
Yes. So certainly significant benefit for endometriosis, both for management of dysmenorrhea, pelvic pain, and recurrence of disease as well. And it's a great option for those patients. And, depending on the side effect patients are experiencing, often one where they may have less systemic side effects. For management of uterine fibroids, it really depends, I think, on the size and location of the fibroids. So certainly if they have a submucosal fibroid or one with a substantial submucosal component, like a FIGO type 0 or 1 fibroid, an IUD is not going to be effective and often will be expulsed because of the fibroid. But many patients have an intramural fibroid and have heavy menstrual bleeding. It may be challenging to kind of determine the contribution of that fibroid to the cause of heavy bleeding. And in those patients, if their cavity is fairly normal size, then certainly a levonorgestrel releasing intrauterine system is a very appropriate option.
Great. So there's a question about the cost of Relugolix and would it be covered by insurance?
Yes. Perfect. Yeah, so some of the practical questions are coming out. Like any new therapy, it will be, the costs are pretty similar to a GnRH agonist cost.
See, it's quite cheap. It's $9 a day. It's $270 a month. How much is it in Ontario?
It's about the same, yeah.
Yeah. Mm-hmm.
What we anticipate and sort of what we're seeing is that typically it will be picked up by private insurance companies first, and this is where you may have to do some advocacy for patients, and then we're hoping to see the provincial insurance pick it up, but that will come later. So it's anticipated that about 50% of patients will have coverage, obviously being those that have private insurance coverage.
There's a question about, with the add-back formulation, is it enough to be contraceptive?
Yeah, so patients have full menstrual suppression still. So it's the same. If they're taking it regularly, then it's the same as taking GnRH agonist. But these medications are all not indicated for contraception. But the Relugolix with combination therapy, like I said, if patients are taking it regularly, then it will be contraceptive. Mm-hmm. I'll just compare it to the other GnRH agonists that we have available, where at the partial suppression dose, Elagolix is definitely not contraceptive. About at least 20% of those patients will ovulate, so they need another contraceptive option.
Yeah, the 150 a day. So the question about fibrostol, not a comparison to fibrostol, those of us who used it a lot when it was available were very sad to see it go. Can you address if there's any need for liver surveillance while on relugolix and on the concerns which led to the stoppage of fibrostol worldwide?
Yeah. So I mean that's a big topic. They're like really different molecules, and relugolix is not thought to be cleared by the liver. I mean, many medications are cleared by the liver, and so this is like one of the top reasons that drugs are stopped in production or fail phase 1 or 2 trials. So certainly in the studies that were conducted, they didn't see any concerning where patients were monitored for a liver, as well as obviously everything else. Echocardiograms to look at QT interval and all of those things, they didn't see any concern. So right now there's no advisory to monitor liver levels.
Yeah, I would agree. It's a completely different molecule to the SPRM, the fibrostol. Is there evidence that relugolix reduces fibroid volume size? I think you addressed that a little bit. Maybe you can kind of speak to that a little bit more.
Yeah, so there is a little bit of reduction, but it's quite minimal compared to placebo. So it's not sort of your choice of agents if you're looking for reduction. It hasn't been compared head-to-head against a GnRH agonist, but we see obviously a very significant reduction with use of leuprolide alone of fibroid size. So relugolix would be what you turn to if your main goal is to manage heavy menstrual bleeding. Obviously, we have not had this therapy available in Canada, but it has been available in Europe and the US for a couple of years. And, what I've heard from international gynecologists in terms of what they sometimes do is then start those that have large sizable fibroids, they'll start them on a GnRH agonist alone, and once they have the fibroid growth reduction, then they'll switch them to relugolix with the estrogen and norethindrone acetate added in.
So that's a cool idea. The question is, can we use this in women still wanting fertility in the future? And is there a limit to how long we can keep them on it right now?
Yeah, so I mean, the studies that we have available right now are for 2 years. So I mean, as I said, it's been available in other countries, I think in US since 2021, in Europe about the same time. So we'll have sort of headway real world data from others as it comes. But that's what we have available right now. And future pregnancy is not contraindicated.
Great. I like this next question. I like them all, but this one is dear to my heart. Are you aware of any ongoing work as far as producing treatment pathways guidelines for dysmenorrhea? As a learner, I've been observing quite a bit of reluctance from family medicine to initiate treatment for suspected endo, only to be referred to gynae to get Dynagest, and wonder if there are resources that are being created or in the process of being created to help bridge this gap and improve treatment at presentation.
Yes, thank you. There's a lot in that. I would say certainly, there's a lot of effort and a lot of conversation, and Dr. Allaire, myself, and many members of SOGC, as well as other Canadian gynecology groups, have been doing a lot of work to bring these conversations to the forefront and involve primary healthcare providers as well as other healthcare providers providing care for patients with endometriosis and uterine fibroids. Certainly SOGC has a number of initiatives. They've received a large Health Canada grant along with the Endometriosis Network of Canada to move some of this work and raise awareness for endometriosis. I'll speak a little bit outside of SOGC. CanSAGE, which is the Gynecologic Society, is also working on this and a little bit more specifically bringing in resources that help our primary healthcare providers as well.
Yeah, there's lots of exciting work. We realize that's definitely a gap in the care of patients with endometriosis, and to get to earlier access to better treatments. So for sure, there's a intense work being done in that area. What do you suggest for initial endo workup from a primary care perspective while waiting for gynae appointment?
Okay. Yes, so thank you. I think, a good history and physical exam to, guide your suspicion of potential contributors of, what patient's symptoms they're presenting with, to either help you rule in or rule out endometriosis. We know that although, a history and physical can help us along, there's no specific sort of algorithm or define, one question that is going to make or break the diagnosis. In speaking of really moving forward our, or dealing with the delay to diagnosis, one of the big limitations has been quality of imaging. So we'll typically start with a pelvic ultrasound. Again, you may consider other investigations if you're suspecting other conditions, so pelvic inflammatory disease or potentially GU or GI contributors to the patient's symptoms. But typically an ultrasound, and I would really implore people to kind of reflect on the imaging quality in your own area, to read through the reports and see what kind of information they have, because not all ultrasounds are of the same quality, and certainly many patients that we see have been told for years that they have a normal ultrasound when they do have significant endometriosis. If patients are presenting with symptoms and dysmenorrhea, you can certainly also treat those while they're waiting to see a gynecologist with either combined hormonal contraceptive if there's no contraindication, or some of the other options that we discussed, the progesterones, IUS, potentially some of the other ones if you're comfortable. I don't know if you have anything to add, Dr. O'Leary.
I would just make the point that imaging can be helpful to see certain subtypes of endo, like endometriomas or deep endometriosis, but will not show peritoneal endometriosis, which is by far the most common type of endometriosis. So at the same time, when someone has a negative imaging, it doesn't mean they don't have endo. So often patients get dismissed maybe because their imaging is negative. So that is not, by all means, not sensitive for detecting all types of endometriosis. And I agree with everything else you've said. There was an article that our group wrote in the CMAJ on diagnosis and management of endo for family practitioners. So that might be another resource for primary care people that are attending this meeting tonight. The next question we have is, there's a request to share the Barbieri curve, the estrogen threshold, after this talk.
Sure.
Be included. And there's also a question whether the slide presentation can be shared. I did share at the beginning that this whole webinar will be available on the SOGC website. I'm not sure if the slides themselves can be shared. I'm not sure what the plan is for that.
I would agree with you that the plan, maybe somebody from SOGC can speak up, but I think the webinar will be recorded and available.
Yeah, so all the slides will be kind of in the webinar. All right, the next question, we have 7 minutes left. So people, if you have a burning question, put it on the chat. Is about Elagolix 150 milligram dose, asking if contraception is required, and if it is, obviously maybe the OCP might not be a good idea because we're trying to lower estrogen. So would an IUD be a good choice in that circumstance?
Perfect. Yeah, so they absolutely need contraceptive. As I said, about 20% will ovulate, and there were a number of pregnancies in the trials. In their product monograph, they suggest either non-hormonal contraceptive options, or they can have a progestin only option. So I find practically patients don't typically like taking like 2 different pills, but an IUD actually works really well. And again, from a practical point of view, adding in the Elagalix to an IUD can often help with the breakthrough bleeding and improve the pain response as well, because they're really like different mechanisms. With the levonorgestrone IUS, you're not getting the ovarian suppression. So now you're having that from the Elagalix, as well as, you know, all the other mechanisms of action from the IUS.
Yeah, it's actually a nice combination, really, for patients. We have a question about, so there's clarity about Lupron alone being great for fibroid size reduction, Myfembree being quite good for heavy menstrual bleeding, but maybe clarify the role of Elagalix. Is it good for what? What's it good for? Fibroids? Is it good for, first of all, just clarified, it's not approved for fibroids in Canada, so let's just start with that.
Yeah.
So I think there's a question, is it good for fibroid size or heavy menstrual bleeding, one or the other, but maybe you can address where the use of Elagalix is in Canada.
Yeah, sorry. So everything has to be super confusing. So I guess to summarize, Relagolix is indicated in Canada for endometriosis, so endometriosis related pain, and heavy menstrual bleeding related to uterine fibroids. As we know, Lupron or a GnRH agonist alone without add-back is helpful for heavy menstrual bleeding and fibroid size and endometriosis. Elagalix in Canada is indicated for endometriosis only, so endometriosis related pain. In other countries, it is available at a different dose for treatment of fibroids. So in the interest of all of that, hopefully what I've just said has clarified things and not confused people more. But I won't go into the, bleeding fibroid management with Elagalix.
Thank you. And then there's a good question about Lupron and flare and when to initiate add-back. So should we wait till the flare is over, and how long does it take for the flare to subside before initiating add-back HRT?
Yes, I mean, you can try giving it and time it in the cycle so they don't get a flare. There's a couple of other ways to mitigate the flare if that's a significant concern. So either with bleeding, pain, or sometimes in patients where the heavy bleeding would be really if they're already very, very anemic. So we're really trying to avoid that. So I would start the hormone therapy after the flare is done. It's usually about 10 to 14 days. Other ways to mitigate it, aside from timing it appropriately, would be to either give an aromatase inhibitor or a GnRH antagonist as well. So both therapies for about 10 to 14 days, and then just switch to the
and can you specify when by timing it? So when would you time it with the cycle, just so people are clear to avoid the flare?
So in the follicular phase.
You mean premenstrual?
Sorry, yes.
Luteal phase, right? The luteal phase. So I usually tell the patients to start it the week before their period is due, kind of thing.
Yes, sorry, I apologize.
Yeah, that's okay. And Dr. Francoeur did confirm that the slides will also be available as well as the webinar recording for members on the website. There was a question about endometriosis treatment with Lupron and which add-back do we use? What do you recommend, estradiol and progestin, or what add-back options would you suggest?
So you can actually use norethindrone acetate alone. There's some conversion to estrogen, and it's sufficient so we can use norethindrone 5 milligrams alone for bone density, and especially in the patients where estrogen, for whatever reason you're wishing to avoid it. Or typically we give at least kind of the menopausal hormone therapy doses, which obviously there's a lot of different combinations.
Right. And finally, final question, what are the costs of the 2 doses of Elagalix?
Oh, I don't know if I know that off the top of my head. They're
the same.
Yeah.
They're the same.
Yeah.
So it's about $400, equivalent to Lupron, $400 to $450 a month, depending on the province and stuff. And interestingly, it's the same cost whether you do the 150 or the 200 BID. That's how they priced it. Yeah. I think that's all we have time for, and we're right on time. So thank you to everybody. Thank you to Olga and Dr. Bougie for an excellent talk and for your insight and experience. And thank you to everybody for the very good questions, and for SOGC for facilitating this event. And hopefully we can have more such events and get all together and improve everybody's management of these very difficult patients sometimes. So thank you.
Thank you so much for both of you. Good night, everyone. And please send us your feedback and comments. Thank you.